This is the Neurosurgery Podcast.
Welcome back to the Neurosurgery Podcast. We are here in San Antonio, Texas. I am very delighted to be with a mentor of mine, Dr. Regis Haid, former AANS president, former NREF chair, former spine section chair. You've done everything. You've lived a life.
I'm old. Yeah, that's exactly right.
So it's funny, right?
Yeah.
Like as neurosurgeons, we live for these moments where something comes along that changes how surgery's done. And you and Chris Shaffrey have hit on something that everybody who hears about it is like, I got to do this now. So you want to take us through some of the history, the recent history of what's going on with Pillar?
Sure. Well, I'd be happy to. Well, let's set the stage.
Yeah.
So I started eating pedicle screws in the late 80s. People goes, what are you doing? That's nuts. Neurosurgeon shouldn't.
Cervical pedicle screws.
Lumbar pedicle screws.
Lumbar pedicle screws, okay.
Okay, and then we started doing thoracic pedicle screws with Dave Pauly, Larry Lincoln. You go, you guys are nuts. And what we saw was we got better fixation, better correction for deformity, tumor trauma, shorter segments, greater correction.
What year was that?
Oh, God.
80s? 90s?
Early 90s.
Early 90s.
Early
okay.
90s. Chris Cummey was my fellow. And then in 88, Paul Cooper brought over Roy Kimmy plates, and I introduced lateral mass plates. And people goes, what are you doing using cervical lateral mass plates? Wires are great.
So now we're in the neck. So now you're doing neck surgery, instrumentation.
Now we're doing neck surgery. Volker and I and a few others introduced cervical plates. They go, what are you doing? Halos work great, et cetera, right?
All these have been adopted.
All
broadly.
these have been adopted, but at the time we were told, you guys are nuts.
Yeah.
Why do this? It's too risky.
Yeah.
So as you know, about 18 months ago, you and I and Shaffrey and Paul Kim were out at Seattle with Rhonda Scullion's lab. And they said, would you guys look at this minimally invasive technique of the pedicle inlet? And so I did an incision like this, perimedian. Shaffrey did an incision like this. You did a small incision. And we said, this is phenomenal.
So cervical instrumentation, posterior.
Posterior cervical instrumentation to the pedicle inlet. And again, I've done cervical pedicle screws for 30 years using navigation. High risk. If you look at the literature, 3 to 5% complication rate for tubular artery.
But the Asians use it a lot. They talk about it anyway.
But they're better. They're better. But you're Asian, you're better technician.
But their bodies are smaller, right?
Their bodies are smaller. And so again, I can place C6, C7, T1 pedicle screws, no problem.
Okay.
C3, 4, issue. And you have to be very lateral. So when I first saw my first pedicle screws, it's by Harms. Harms did a midline incision, did a percutaneous angle to get the lateral to medial angulation for a C5 pedicle screw.
So just for audience who don't do spine surgery, right, to give you some concept, what we're talking about is in the neck, you need to get screws to hold things together or move things around or whatever, just like if you broke your neck, right? But if you do a lateral mass screw, then you're doing like a short screw that kind of aims out. And then if you do a pedicle screw, it's a really long one, right, that aims in past the cord.
So the lateral mass screw is the best thing we have, but it's not as strong. Okay. If you do a pedicle screw, it's very strong, but it's high risk to the vertebral artery that goes to the brain. It's high risk of the nerve root. It's high risk of the spinal cord.
So you could get a stroke, you get paralysis, you get a weak or painful arm or something like that.
People die.
Okay.
Okay. So Deb from Duke, Chris Martin, an orthopedist from Minnesota, Martin Pham, they started working, and Paul Kim started working on a pedicle inlet technique. So the deal is, it's kind of a bastardization between a lateral mass and a pedicle. So you actually start more medial, a little lower, and you put the screw into the inlet of the pedicle. Now here's the secret. If you look on the CAT scan, the Hounsfield units are very, very strong. So what you do is you achieve a very rigid screw with obviating the risk to the nerve root, obviate the risk to the vertebral artery or the spinal cord, and you get a pillar or pedicle inlet fixation that's very rigid, and the screw heads line up perfectly. So as you know, as you go from C1 to T1, there's an offset, but when you do a pedicle inlet screw, you get less risk, greater rigidity, shorter segment, and your tulip heads line up perfectly so you can drop your rod in.
Kind of like a short pedicle screw.
Yes.
And it's hard to describe, so for audience, listening, especially just driving or whatever, it's one thing. I think we'll have JP post a link to maybe Deb Boehmwick and Chris Martin's paper. That way people can go to the literature.
Well, there's a link, and there's also some videos that we can link to as well on certain websites, not to advocate for any particular company, but there are some links to websites that
Kids love videos now. They can see that
actually
they
show
know how
the
to do
cartoons.
surgery. Yeah,
right.
Yeah, okay.
And so you and I are there, and we're going, holy mackerel, this is something. And this was 18 months ago. So for the past 18 months, you, Chris, Paul, Kim, and I have worked on a technique where you hold the head in a Mayfield with a device called a caption.
Now, I have not done any. You guys took this way further. I was just initially there. I didn't know all this other stuff. So please
stop being humble. So we have the patient rigid in a Mayfield. We have a device that holds the head 92% more rigid. We have a clamp that Kristen Jones of Duke showed us. It's the Medtronic Next Gen 5 clamp, or we call it the pillar clamp, that holds the spinous processes in place. So when you drill, the spine doesn't move.
There's too much movement, right?
Too much movement. Okay. So between and you can't do this with tongs, so between the Mayfield, the caption head holder, and this clamp, using navigation, you now use a Midas Rex 2.0 millimeter pillar bit, which doesn't have a side cutting burr. It's just a straight burr. And so you drill to the pedicle inlet where the bone is very strong.
Oh, so you don't inadvertently drill a bunch of extra bone that's going to weaken your purchase.
No, and so your exposure is more narrow.
Yeah.
So instead of starting lateral, you start more medial and a little bit lower.
Okay.
You put a stronger screw, and if Jeff Gum from Leatherman has shown if you start a little bit lower and angle up, you can place a 14 to 16 millimeter screw. If you start more lateral, aiming toward the pedicle, you can place a pedicle screw, but that screw is about 10 to 12.
If you're interested, definitely you need to look at the videos and the diagrams because it's hard to explain, although Reggie's doing a great job. But let me ask you a different question about this. So we're here in Exhibit Hall of the AANS in San Antonio 2026. Wonderful meeting. There's probably like 200, 300 exhibitors here. Right. Everybody's hawking wares. Everybody's talking about try this new bipolar.
Right.
These guys over here are selling hotel business. Everybody's selling, right?
Let me explain. But this is transformational.
Why is it transformational?
Because this is when we started doing lumbar pedicle screws, it became transformational.
But why? Well,
we got segmental fixation. When we started doing thoracic pedicle screws, became transformational for scoliosis. Can you imagine, Mike, doing a thoracic tumor trauma scoliosis without doing pedicle screws? Can you even imagine that?
Oh, I was in it. When I was training, people were using wires still. So
right. But I mean, today, can you imagine that?
It'd be like they think you're in the third world or something. Yeah.
So this is transformational. This new angle, it's the same screws. It's not a different screw.
Okay.
It's the same screw, but it's using a procedure that's involving holding the head, navigation, and directing a screw to the pedicle inlet, which is the strongest part of the bone. And as we get older, osteoporosis, I'm an old guy. Osteoporosis is an issue. The pedicle inlet actually gets stronger with greater density. So now as you get older and fighting osteoporosis, we get a greater bone purchase, shorter segment fixation, the tulips line up, you drop your rod in, it's fast. And because the tulips are out of the way, you can actually do your screws first and then do your laminectomy, so you're not placing your screws with an open dura.
So I've wondered about this because, like, after the lab, I tried it, I really liked it, and then I started talking to other people, and they seem to like it too.
Right.
But what's the stickiness on that? Like, people are always wondering, like, why is it that like I haven't seen anything new in the spine, honestly, in a long time, like 20 years.
Right.
Nothing new.
This is new. This is
new that works, I should say.
This is when we started doing thoracic pedicle screws, it changed how we think, it changed how we do scoliosis, it changed how we do trauma, deformity. So we're doing this technique open. However, Paul, Kim, and others are doing paramedian incisions, and Deb Boehmwick at Duke is doing it percutaneously. And now so this is going to be just like you do thoracic percutaneous screws. It's going to happen. It's not there yet, but so now if we have a thoracic lumbar burst fracture, Steve Levick just talked about, you place pedicle fixation without a fusion. If you have C1-2 instability or fracture, you place without fusion, just fixation. I believe with cervical fractures, you're going to place this in the future, place this percutaneously, the fracture will heal. So to me, this is the most transformational thing in spine posteriorly I've seen since thoracic pedicle screws.
Yeah, I mean, you've been there for everything. Anterior plates, like you said.
I'm so old.
Fixation.
Yeah. I mean, I'm before lateral mass screws. I'm before lumbar. I was a third neurosurgeon who did lumbar pedicle screws.
Wow.
This is going to change how we do everything. Every surgeon will be doing cervical pillar or pedicle inlet screws because it's fast, it gives great fixation, but it demands navigation. So even Chris Shaffrey, who's a dinosaur like me, if you use navigation and this 2 millimeter drill bit, it goes perfectly. Now the downside is the bone is so hard, you either have to over drill a couple millimeters or over tap a couple millimeters. So if you place a 14 millimeter screw, you have to drill or tap either 14, 15, or 16 millimeters, because as you're putting that screw insertional torque, it is so strong, it'll start to spin.
Wow.
Because the bone purchase is that good.
Well, you heard it here first, the Pillar, P-I-L-A-R screw. Look at the links, the videos,
Yes.
the literature, very exciting. Reg, thank you. You're always pushing the envelope, making things better for our patients.
Mike, let me explain something. This will transform spine surgery. Lateral mass screws, which I helped introduce, they're going to go away. This is going to change how we do surgery.
You heard it here first.
Thanks.